A very good evening, my dear friends. This is Dr. Azam here, your faculty of anatomy at PrepLadder. And now we are here with image-based session as well as a video-based question session. And we know that we are like very much near to the exam, like hardly no time left for the exam, NEET PG exam, which is scheduled on 30th August. And my dear friends, I have come up here with a quick session wherein I'm going to deal with all the high yield images that you have to refer before going to the exam. So you must see these images and go to the exam. And apart from that, these images will be also including all the images which were given in the NEET PG exam in the previous year questions, or we can say the previous year topics. So in less time, my dear friends, remember, बहुत ही कम समय में हम क्या करेंगे, we'll try to quickly revise all the images which are required for your NEET PG. So please just focus here and try to recall. There is nothing to write here, nothing about the PDF and all those things. Just focus along with me and try to recall the things. Now the first video based question that I have kept here, and the very important concept for the NEET PG exam, my dear friends. Actually, what is happening here right now, I'm working out in Notability here. So these videos are not playing right now. So just imagine there is a video here wherein you're going to touch the posterior pharyngeal wall and you are trying to do the gag reflex over here. एंड ये क्वेश्चन आपके नीट पीजी एग्जाम में कई बार रिपीट किया गया. इट्स रिपीटेड क्वेश्चन इन नीट पीजी एग्जाम अबाउट द गैग रिफ्लेक्स एंड इवन अ इमेज बेस्ड क्वेश्चन वाज गिवन where in you're touching a cotton swab onto the posterior pharyngeal wall, and they're asking you about the afferent as well as the efferent nerve here. So remember, in the gag reflex, the afferent here will be the ninth nerve, whereas the efferent here will be the 10th nerve. The afferent will be the glossopharyngeal nerve, whereas the efferent here will be the vagus nerve. Then second important concept which was given in your NEET PG exam was about the extravasation of urine. Now, extravasation of urine, the video that is actually shown here, a person riding a bicycle on a bumpy road. When the person is riding a bicycle on the bumpy road, then what is going to happen? This type of injury is actually referred to as straddle injury. Now, please remember, let us repeat the entire concept here about the extravasation of urine. You need to look at the keyword. The keyword here is straddle injury here. The moment in the exam you see a straddle injury or a person riding a bicycle on the bumpy road, remember the urethra that will be ruptured will be the bulbar urethra. And if the bulbar urethra is ruptured, remember the urine will be going in superficial perineal pouch. It will also go into the scrotum, into the penile shaft, as well as the anterior abdominal wall. So this key word is very much important here. Now the second thing, if you look at this word, that is pelvic fracture, which is already a PYQ in your NEET PG exam. The moment you see this word, that is pelvic fracture, then you have to understand that membranous urethra is ruptured. And when membranous urethra will be ruptured, remember the urine will be going into the deep perineal pouch as well as the space of YRCIS. Now from like many years, we have been learning that, where the urine is actually extravasating out. But in the exams, they're even asking you where the urine cannot go. So if bulbar urethra is actually ruptured here, remember the urine cannot extravasate into number one, thigh, due to which fascia? The fascia lata present in the thigh. Number two, the urine cannot go into the deep perineal pouch because of the presence of perineal membrane over there. And it cannot go into the ischiorectal fossa due to the Colles fascia. So you have to remember that. I repeat again, when bulbar urethra will be ruptured, the urine cannot go into the thigh because of fascia lata, and the urine cannot go into the deep perineal pouch because of the perineal membrane, and the urine cannot go into the ischiorectal fossa due to the Colles fascia. So this is the entire concept that we have revised about. Second concept, that is extravasation of urine. Now third and the very important thing, I'll tell you why. Fine. Now please look at this question here. The artery palpated in the given video is present between. First of all, we know that this one here will be your tarsal tunnel here, guys. And in the tarsal tunnel, the artery that you're actually going to palpate here will be the posterior tibial artery. And they are asking you, the posterior tibial artery is actually between which two structures? And we all know the concept of tarsal tunnel. Tarsal tunnel, yes, all these structures are arranged in the form of that mnemonic also, you remember very well, Tom, Dick and Nervous Harry. So Tom, T stands for tibialis posterior, and then D stands for flexor digitorum longus, and A stands for artery, that is posterior tibial artery, which is very much important nowadays for your exams. And then there is be a nerve here, that is your tibial nerve, and finally there'll be the flexor hallucis longus, H for Harry. So Tom, Dick and Nervous Harry हम ऐसे पढ़ते हैं इसको, ठीक है ना. Now you can very clearly see in this diagram, this is the posterior tibial artery, and that artery is actually between the flexor digitorum longus tendon and the tibial nerve on the other side. Fine, fine. But the important thing why I have included this image over here is, remember, this is your entire tarsal tunnel, and the tarsal tunnel is formed where this band of fiber will be referred to as flexor retinaculum, and the flexor retinaculum is between the medial malleolus and the calcaneum. That flexor retinaculum is between the medial malleolus and the calcaneum. And now, my dear friends, once in your exam, this image was also given. The doctor is trying to measure the pulse with the help of which artery? Again, the same answer, posterior tibial artery. Fine, fine. This is all okay. You might have even learned that, and I think you are actually revising along with me right now. But your NEET PG examiner is very much fond of this tendency here, sir. Okay, the NEET PG examiner is very much fond of this tendons over here. Please observe this diagram very carefully. Now this one here will be your medial malleolus over here. And just behind the medial malleolus, you are able to see one tendon. And this will be the tendon of tibialis posterior tendon. So if they're giving you in the exam, already given in the exam, just behind the medial malleolus, it will be tibialis posterior. Then now, my dear friends, we are able to see this one here will be the flexor hallucis longus. Okay, this tendon here will be the flexor hallucis longus tendon. Now, sir, how to identify this one here? Actually, what happened is this bone here will be your heel bone, that is your calcaneum. And calcaneum will be actually having a projection here. This projection is referred to as sustentaculum tali. Sustentaculum tali. I repeat that again. Okay. Now, why the name is given like that? Why? Because just above this one here, you'll be having talus, and this is going to support the talus over there. That is why it is written as sustentaculum tali. And if you see a tendon going just beneath the sustentaculum tali, bang on, that is flexor hallucis longus tendon. Flexor hallucis longus tendon, and you can see it is going all the way up to the great toe hallucis. And now the tendon which is going to actually cross this and go obliquely to the digits, this one in the middle here will be the flexor digitorum longus. So this which is going obliquely here like this, crossing that and going obliquely, this one will be the flexor digitorum longus. Are you understanding me? Your NEET PG examiner is actually fond of this tendons like anything, I'm telling you. That is the reason why it's worth repeating. Let us repeat this once more. चलिए दोबारा करते हैं. Medial malleolus के बिल्कुल पीछे, just behind that, the tendon present here will be tibialis posterior. And then just beneath the sustentaculum tali, this one here will be the flexor hallucis longus tendon. And then this one here in the middle will be the flexor digitorum longus. It's going to the digits over there. Please remember this diagram. And similarly, I have given you a cadaveric image also. So just behind the medial malleolus, there will be tibialis posterior, and then we'll be having the flexor digitorum longus, and you can very clearly see the flexor hallucis longus going beneath the sustentaculum tali. I hope it is perfectly done. It's a repeat question in your NEET PG exam. That is why this image is mandatory to be revised before going to the exam, sir. Now let's go ahead with the next concept. Now identify the medial and the lateral pectoral nerve here, and this question was exactly given in your NEET PG 2024. This image was given. Now in this image, I don't have to worry about A here, that is pectoralis minor muscle, originating from the rib number 3, 4 and 5 and going and getting inserted onto the coracoid process. And what is that big muscle which is reflected here, this B here? This one will be the pectoralis major. Now the question comes, how to identify these nerves over here? Okay, fine, they're pectoral nerve, fine, but there are two of them. One is lateral pectoral, another one is medial pectoral. Now try to recall between the clavicle here and pectoralis minor here, यहाँ पर एक fascia होता है, and that fascia will be the clavipectoral fascia. And it is one of the old question, what are the structures piercing clavipectoral fascia, है ना? So now what are the structures piercing clavipectoral fascia आपने पढ़ा होगा, and one of the structure will be the lateral pectoral nerve. So by this you can easily identify the nerve which is actually piercing and coming here, that is your lateral pectoral nerve. Now, what is the nerve which is actually supplying to pectoralis minor muscle? Remember, that will be the medial pectoral nerve. Medial pectoral nerve, अगर इसको pierce कर रहा है, the nerve that is going to pierce the pectoralis minor, it is going to supply to that one. So this has to be the medial pectoral. एक बार मैं दोबारा repeat कर देता हूँ. The nerve which is actually going to pierce the pectoralis minor muscle, it has to be the medial pectoral nerve. And the one which is piercing the clavipectoral fascia here, that one has to be the lateral pectoral nerve. Okay, so this exactly the same image was given in the NEET PG exam. NEET PG examiner is very much fond of cadaveric images. That's the reason why I've included all these cadaveric images over here. Yes, that's really nice, Dr. Rajput. I think you're answering correctly over there. A patient presenting with the right-sided shoulder droop, okay, shoulder drop, and the absent gag reflex. There is a shoulder drop and there is an absent gag reflex. Which of the following structure passes through the posterior part of the involved foramen? Shoulder drop, trapezius muscle will be involved. Trapezius will be supplied by the spinal accessory nerve, 11th nerve. And just now I told you on gag reflex, it will be the 9th and 10th nerve will be involved here. That means 9th, 10th and 11th nerve. And they are passing through which foramen? Of course, the foramen will be the jugular foramen. But what are they asking here? Yes. In jugular foramen, all these structures are going to pass here. Okay. Apart from the 9th nerve and the 10th nerve and the 11th nerve, my dear friend, there will be inferior petrosal sinus as well as the sigmoid sinus. So anteriorly there'll be inferior petrosal sinus and posteriorly there'll be sigmoid sinus. And what is the question here? What is the structure passing in the posterior part of that one? It will be the sigmoid sinus. Basically my intention here is about what are the structures passing through jugular foramen. चलिए हम लोग मिलकर रिवाइज कर लेते हैं. Wherever you are sitting and listening to me right now, my dear friends, try to revise these things along with me. It's not like a regular class where a teacher is teaching you and you are freshly learning right now. थोड़ा सा recall कीजिए quickly, actively recall कीजिए मेरे साथ में, ठीक है ना? Yes, what are the structures passing in the jugular foramen? Inferior petrosal sinus, 9th, 10th and 11th nerve, and then the sigmoid sinus. Now, out of this, one more important MCQ is 9th nerve will be the one which is present in the separate sheath here, whereas the 10th and 11th are present together in the common sheath here, my dear friends. Yes, perfectly right. Okay. Dr. Siddhant, yeah, we are actually dealing with the NEET PG like quickly here because they're just left out with couple of days right now. I also have heard about this one, the updates which are coming just before starting with the session. When I was actually preparing for this session, I also heard about those updates coming. So let us just wait for like another few minutes. When we get the final updates, official updates, then we can actually speak about that, because right now even I am not perfectly confirmed about all those updates. Okay, we'll come up with that one. Okay, yes, thank you, Dr. Siddhant. Now, which of the following is the action of the muscle marked in the given image? Another hot favorite concept of your NEET PG examiner. Now, my dear friend, one thing is, what I have observed is that every medical student knows that there are totally 4 muscles of mastication. Perfect. Every medical student will be able to identify masseter, no doubt about that. Every medical student will be able to identify the temporalis. No doubt about that. The problem will come with the lateral pterygoid and medial pterygoid. And the trick here is that, remember, the muscle which is going and getting inserted onto the temporomandibular joint here. The muscle that is getting inserted onto the temporomandibular joint, this one will be the lateral pterygoid. And the one which is attaching to the ramus of the mandible here, again the ramus of the mandible here from the inner aspect, that will be the medial pterygoid. That is how you have to identify. Okay, so focus and try to smartly revise the things. Lateral pterygoid is actually going to attach to the temporomandibular joint, and medial pterygoid is the one attaching to the ramus of the mandible from the inner aspect. And please don't get confused with this one here. This is buccinator muscle. And buccinator muscle is actually the accessory muscle of mastication. Okay, it is the accessory muscle of mastication. So I hope now my students will be easily able to identify. Now in this image here, this muscle here will be the lateral pterygoid muscle. And all my students who have actually studied in our classes, who have watched my videos on PrepLadder, they know very well. Remember, lateral pterygoid, L for lateral pterygoid, and there is only one muscle helping in lowering the jaw. It is helping in lowering the jaw. If it is lowering the jaw, elevates, I mean to say, ये दो option मैंने rule out यहाँ से कर दिया है. It is going to lower the jaw. And then, my dear friends, it's going to lower the jaw. But remember, retraction of the jaw, it's done by only one muscle, that is your temporalis muscle. So temporalis muscle is the one which will be actually helping in retraction. So it's not going to be possible with lateral pterygoid. So the correct answer here will be the lateral pterygoid is going to lower the jaw, depress the jaw, as well as protrude the jaw. Okay. And now, my dear friends, please remember that Yes, for muscles of mastication, in my workbook, I have given you like five statements, five sentences over there. And with that 5 points, you can answer any question related to muscles of mastication in this manner. You can easily rule out the things. Okay, so we are done with the image-based question here. All the images are done here. You're able to identify each and every muscle of mastication and you'll be able to solve the question, guys. Yes. Another very, very important thing for your exams nowadays, sir. That is mandibular nerve. That is your 5-3. Mandibular nerve will be actually first of all having a trunk, and that trunk will divide into two divisions. One is anterior division and posterior division, guys. Now remember, anterior division is actually going to take care about the muscles of mastication. ये सब आपको अच्छे से पता होगा कि trunk will be supplying to only one muscle of mastication, that is medial pterygoid, whereas anterior division will be supplying to the lateral pterygoid, the temporalis and masseter. Yes, I'm trying to tell you all those points right now which normally the students will tend to forget here. Okay, ये तो आपको पता है, सबने पढ़ रखा है. I repeat again, muscles of mastication will be supplied by mandibular nerve. In that, trunk will be supplying to one of the muscle of mastication, that is medial pterygoid, and remaining muscles of mastication are taken care by anterior division. Now the most important thing is the posterior division, and I am expecting a question from here. After a couple of days, when you're going to write down the NEET PG exam, I'm expecting a question from the posterior division. Yes, very good, very good. Posterior division will give rise to three branches, that is Ali branches. Now quickly recall, my dear friend. A stands for auriculotemporal nerve. नाम में लिखा है, it is supplying to the upper 2/3 of the auricle here and the skin of the temporal region, auriculotemporal. And this joint here, temporomandibular joint, and this gland here, that is your parotid gland, very much important. And if the auriculotemporal nerve is injured, you know very well, when it's trying to regenerate, it most commonly joins with the great auricular nerve over here, and that will be leading to gustatory sweating here, Frey syndrome. तो यहाँ से याद रखिए important है, हाँ, तो auriculotemporal nerve is important for Frey syndrome. And recently in the NEET PG exam, they asked about the nerve supply to the skin over the auricle. The nerve supply to skin over the auricle has been asked. And next, coming to the lingual nerve. Lingual nerve is actually going to pass here via a ganglion. That ganglion will be submandibular ganglion. That's how you'll be able to identify. Now, what I'm trying to show you in this diagram here, first of all, you're able to see a gland here. This one will be the submandibular gland along with its duct, that is the Wharton's duct. And this Wharton's duct, you can see the way it is traveling here. Normally in your exams, what they're giving is submandibular gland resection. Due to some reason, when you are trying to remove the submandibular gland, the most common nerve to be injured there will be your lingual nerve, sir. This lingual nerve will be most commonly injured. So ये सवाल यहाँ से आ सकता है. And lastly, I actually stands for inferior alveolar. And from the name itself, you're able to understand here, inferior alveolar. Inferior alveolar. What do you mean by that one? It is actually going into the lower jaw. That is nothing but your mandible. It's going into the mandible via one foramen known as mandibular foramen. So please try to remember about the name of that foramen they'll be asking you. So all the three branches from the posterior division, that is Ali branches, and all the MCQs I have actually revised here. Please remember them carefully. Next concept to be learned. Of course, what is the nerve supply of the following muscle here? This one here will be the anterior belly of digastric here, and this is the posterior belly of digastric. Anterior belly of digastric muscle that will be derived from the first arch, and first arch mandibular nerve will be supplied to that first arch. And mandibular nerve का यहाँ पर कौन सा वाला branch उसको supply करेगा? Obviously, the mandibular nerve will be giving finally here the nerve to mylohyoid. So option A here will be actually taken care by the nerve to mylohyoid. And yes, option B here, the posterior belly of digastric. That is derived from which arch? Second arch. And if it is derived from second arch, obviously all the muscles from there will be supplied by your facial nerve, guys. So nerve to mylohyoid and the facial nerve will be supplied to the anterior belly and posterior belly of digastric respectively. Okay. Next image. Which movement will be impaired in the fracture of marked area? Now in the image you are able to see that is femur, and in the femur this trochanter here will be the greater trochanter. And if there is an injury here, then which movement will be impaired? If there is a fracture here, which movement will be impaired? Now basically this image is important. Attachments of femur. From here the question has been asked in almost every exam, whether it is INI-CET, FMGE or NEET PG exam. Now my dear friends, welcome here. Now in this diagram, number one, this one here will be your ASIS, anterior superior iliac spine. Number one, from here to the pubic tubercle, there will be a ligament attached. That ligament will be inguinal ligament. And then there'll be a muscle attached here. That will be the sartorius muscle originating from there. Now this one here will be the AIIS, anterior inferior iliac spine. And from here begins the rectus femoris muscle, originates from here, sir. Now, once you are done with these two things here, welcome to gluteus maximus and gluteus medius and gluteus minimus. Now, gluteus maximus कहाँ पर attach होता है? Remember, it will be attached onto a tuberosity here, and this tuberosity will be gluteal tuberosity. Now, which muscle will be attached here, guys? Gluteus maximus. And it is helping in what? Extension and external rotation at the hip joint. Now you and me, we are in a sitting position. In sitting position, our hip joint here will be flexed. Now from the sitting position, suppose if I'm standing up, then what is going to happen? There will be extension at the hip joint. Okay. Or for example, like climbing up the stairs, at that time, there'll be extension at the hip joint, and that is done by gluteus maximus muscle. The gluteus maximus muscle will be helping in extension as well as external rotation at the hip joint. You remember the example like climbing up the stairs. Now listen to this very carefully, 200% concentration here. Both gluteus medius as well as minimus, gluteus medius as well as gluteus minimus, both of them will be attached at greater trochanter. Medius and minimus, both of them will be attached at greater trochanter. But the difference here is that the medius will be attached onto the greater trochanter posteriorly here, whereas the minimus will be attached onto the greater trochanter anteriorly here. And both of them are actually going to help in abduction as well as internal rotation at the hip joint. और आप सबको पता है कि these two muscles, the medius and minimus, will be taken care by superior gluteal nerve. And if that is injured, then what is going to happen? There will be lurching gait. The person will be lurching on one side and walking, and the sign that will be positive over there will be Trendelenburg sign. Trendelenburg sign will be positive here. Now, what about the lesser trochanter? At lesser trochanter, there will be two muscles attached here. One will be the iliacus, another one will be the psoas major. The iliacus and psoas major will be attached at lesser trochanter. Perfect, perfect, very nice. Now, nowadays in your exam, what I'm observing is this is trending, my dear friends. They are giving this diagram of the hip bone, and then there will be an arrow mark at this spine here, and this spine here will be the ischial spine. Now at the ischial spine, what is going to happen here? Yes, there is a nerve which is going to take a turn, and that nerve will be the pudendal nerve. Along with that, there will be internal pudendal artery, and then along with that, there will be the internal pudendal vein. And we are going to remember these structures with the mnemonic as pin structures. Please remember them as pin structures. I repeat again, P for pudendal nerve, I for internal pudendal artery and vein, and then N stands for nerve to obturator internus. All that three structures are going to take a turn there. They're asking this many, many times. In fact, my dear friends, I'm telling you, this diagram is like so much important, so much important. N number of times ischial spine image-based question has been asked. Recently, X-ray image, lesser trochanter arrow mark has been given. Greater trochanter already it has been given. Even gluteal tuberosity already. Matlab each and every point in this image is very much important. Please revise this image before going to the exam. Next one, patent ductus arteriosus. Now in this image, you are able to see this patent ductus arteriosus. Now, why I have included this image here, it's given like twice in your NEET PG exam in the previous years. I'm telling you about the last 5 years. You can go back and see. And now this they are actually correlating with the development of arterial system. Okay, now in our regular classes already we have dealt with the development of arterial system in detail. Recently I have done the resolved classes also. We have done in detail. Now let us just quickly revise this one here. Number one, there are totally like 6 arch arteries. Out of the 6 arch arteries, we know very well during development, out of the 6 arch arteries, the 5th arch will completely degenerate. So therefore, nothing will be derived from the 5th arch. तो सबसे पहले आप ये भूल जाइए कि 5th arch से कुछ नहीं आएगा. Nothing will be derived from the 5th arch. Now, what is happening with the first arch artery? The first arch artery is not going to form anything. There will be a remnant of that one. And that remnant here will be the maxillary artery. Come on, my dear friends, recall quickly along with me. So what is the remnant of first arch artery? Maxillary artery. Now, what is the remnant of second arch artery? That will be stapedial artery, and another one will be your hyoid artery. The stapedial artery and hyoid artery will be the remnant of second arch artery. Now welcome to the third arch artery, and you can very clearly see it's going to form your carotid arteries. The proximal part of the third arch artery is going to form common carotid artery, and that's going to divide into external and internal carotid artery. Whatever, third arch artery on either side is going to form carotid arteries. Carotid arteries. Now welcome to the most important one, the fourth arch artery. And the fourth arch artery is the one which is going to form the arch of aorta. And that too from the left side. Left fourth arch artery is going to form arch of aorta. Fifth arch artery, मैंने आपको clearly बताया, nothing is derived from there. And then welcome here, my dear friends, sixth arch artery. Sixth arch artery is the one which is going to form your pulmonary artery, the right pulmonary artery and left pulmonary artery. But you can very clearly see in our diagram, not the entire sixth arch artery, only the proximal part of that one. Only the proximal part of sixth arch artery is going to form the pulmonary artery. Then what about ductus arteriosus? Ductus arteriosus, just try to recall, it is present between which two structures? Remember, it is present between the pulmonary artery on one side and the arch of aorta on the other side. The ductus arteriosus is between the pulmonary artery on one side and arch of aorta on the other side. Definitely it has to be derived from the left sixth arch artery. So it is derived from the left sixth arch artery. That too only the distal part of that one. I think now you're able to easily handle this diagram, my dear friends. Is it okay? So in this manner, arch arteries will become easier for you. Now, what about the subclavian artery? That is something important and confusing also. Left subclavian artery is actually derived from where? It is a branch of arch of aorta only. So therefore, it is actually derived from where? The left subclavian artery. It's derived from the left seventh cervical intersegmental artery. I repeat the name again. Left seventh cervical intersegmental artery. Whereas the right subclavian artery is derived from like many structures here. I mean to say three structures here. Number one, the right fourth arch artery, right dorsal aorta, and the right seventh cervical intersegmental artery. Right fourth arch artery, right dorsal aorta, and right seventh cervical intersegmental artery is going to form, yes, right subclavian artery. So by this, we have revised the entire arterial system development. In embryology, I kept this topic here. Why? Because my dear friends, remember this topic, they're asking many times, many questions from here. Okay. Then after that, my dear friends, what about the right and left recurrent laryngeal nerve? चलिए quickly इसको भी revise करते हैं. Left recurrent laryngeal nerve is more longer when compared to the right one. Of course, due to which one here? Due to the sixth arch artery you are able to see here. ये भी सवाल आपके एग्जाम में पूछा गया था. Now moving on to the next concept. A newborn presents with the fecal discharge from the umbilicus since birth. On examination, there is a patent connection between the ileum, that is your mid-gut, and the umbilicus. Which of the following embryological remnant is most likely responsible for this condition? Okay, now what I have observed is from the last 5 years of your previous year topics of NEET PG, they're asking many questions about the umbilical cord and yes, of course, the clinical conditions related to that one. Now, for example, if this one is your embryo, after that cranial and caudal fold, and this one here will be the yolk sac. Basically, this is the body wall of the embryo here. Then after that, my dear friend, the endoderm. Endoderm is the one which is going to form your entire gut here. Now, this one here will be the foregut, then this one here will be the midgut, and this one here will be the hindgut. Midgut will give rise to a duct here, that is vitello-intestinal duct, and hindgut will give rise to this extension known as allantois. And this one here will be the future umbilical cord, my dear friend. That will be the umbilical cord. Fine. Now, what are the contents of the umbilical cord? Number one content that you are able to see here, that is vitello-intestinal duct. Number two content that you are able to see here, that one will be the allantois. Number three content that you are not able to see here, they are surrounded by a jelly-like substance known as Wharton's jelly. And number four here, there will be umbilical artery. और याद रखिए arteries दोनों भी होती हैं, will be having the right and left umbilical artery. And number five, there will be umbilical vein, but there will be only and only left umbilical vein. Extremely important for your exams. दो आर्टरीज होती हैं और एक ही वेन होता है, एंड वी रिमेंबर दैट विथ यस अम्बिलिकल वेन राइट विल रिग्रेस एंड ओनली लेफ्ट इज लेफ्ट, right will regress, left is left. Now in the normal people like you and me, the entire vitalo-intestinal duct has to be gone. But in some unfortunate babies, if the vitalo-intestinal duct is going to persist, then what is going to happen? The meconium present over here is going to come out from the umbilicus. If the meconium is coming from the umbilicus, if the fecal discharge is coming from the umbilicus, yes, of course, it is due to what? It is due to persistence of vitalo-intestinal duct. Makes sense right now. So if this entire vitalo-intestinal duct is going to persist, the meconium is going to come out from the umbilicus. I hope you are able to understanding right now. Now, in some unfortunate babies, what is going to happen? Entire vitalo-intestinal duct is not going to persist. Entire duct will not persist. Only the proximal part of this is going to persist. Distal part will be gone. Only the proximal part is persisting, attached to the midgut. To be more specific, attached to the ileum over there, and that diverticulum is referred to as Meckel's diverticulum. It's referred to as Meckel's diverticulum. Fine. I hope it is very much clear, guys. Yeah, I'm coming to that one right now. Now, further development, let us now come down to hindgut. So I told you about the two clinical conditions related to the midgut. Okay, I repeat again, if the entire duct is persisting here, meconium is going to come out of the umbilicus. If only the proximal part is persisting here, that is Meckel's diverticulum. Now welcome to the hindgut. Later on during the development, what is going to happen is, yes, these two will be separated apart. I mean to say, hindgut and allantois will be separated apart. Hindgut, we know very well, it is the one which is going to form your rectum, anal canal and all. But what happens to allantois? Now remember, allantois is the one which is actually going to form urogenital sinus. And the cranial part of this one will be the urachus. इसको हम urachus कहते हैं. Now what is going to happen? This urogenital sinus is going to form your urinary bladder. Urogenital sinus is going to form urinary bladder, and please remember, except trigone, except the trigone of the urinary bladder, and this has been already asked in your exam कि trigone कहाँ से form होता है, and please remember trigone is actually formed from the Wolffian duct, the mesonephric duct. That's all. तो यहीं पर क्या हो गया सर? We are done with the development of the entire urinary bladder is completed here. I repeat it again. Entire urinary bladder will be derived from urogenital sinus except the trigone. And remember, the trigone will be actually derived from Wolffian duct or the mesonephric duct. Now, the cranial part of this one is urachus, and urachus in the normal people like you and me has to be closed. And it will be closed to form a ligament, and that ligament will be the median umbilical ligament. Please be careful with the spelling there. It will be median, not medial. Median umbilical ligament. So urachus in normal people like you and me is going to form median umbilical ligament. Now what if unfortunately it doesn't close? अगर ये close नहीं होगा, so this urachus is going to remain open. Whatever urine will be present in the urinary bladder here, that urine will start coming out from the umbilicus. So that umbilicus will be like weeping umbilicus. यूरिन इज कमिंग आउट फ्रॉम द अम्बिलिकस, इसीलिए उसको हम कहते हैं वीपिंग अम्बिलिकस. तो अम्बिलिकस लाइक रो रहा है सर, ठीक है ना, और किसके आंसू रो रहा है वो आप सोच लीजिए. तो यूरिन इज कमिंग आउट फ्रॉम हियर एंड इट्स ड्यू टू व्हाट? ड्यू टू द परसिस्टेंस ऑफ यूरेकस हियर. So therefore, my dear friend, someone was asking me over there, if the vitalo-intestinal duct is going to persist, then what is going to happen? Meconium is going to come out of the umbilicus, and if urachus is going to persist, then urine is coming out of the umbilicus. I hope the concept is like crystal clear, and this slide is very much important. Many questions we have actually covered here, sir. Now moving on to another very important concept, epiploic foramen. Now in this diagram, on one side you are able to see here liver, on the other side there is a stomach here, and between the liver and the stomach, this one here will be the lesser omentum. And this lesser omentum has got one attached part here, sir. This is the attached part of the lesser omentum, attached margin, and this one will be the free margin of the lesser omentum. And please be very much careful here. Behind the free margin of the lesser omentum, there is epiploic foramen. Behind, not beside. I'm telling you again, इसके बाजू में नहीं होता है. It is not beside that one. That is the biggest mistake done by many of the students. तो epiploic foramen is not beside this one here, it's actually behind the free margin of lesser omentum. अगर आपने ये समझ लिया है, if you have understood this one here, तो please remember what do you have above the epiploic foramen? Of course, liver. But you got to remember which lobe of the liver. Remember that will be the caudate lobe of the liver. So superiorly, I'm just writing here for the sake of understanding. Please remember, superiorly there will be caudate lobe of the liver, important. Why? Because in exam, the examiner actually sort of confusing you by giving quadrate lobe. So please remember, it's not quadrate, it's actually caudate lobe. And below here, you're able to see the first part of the duodenum. That is your, I'm just writing as D1, the first part of the duodenum. So by this diagram, my dear friends, it's nothing to mug up in our class over here. Above the epiploic foramen, there will be caudate lobe of the liver, and below that one, it will be the first part of the duodenum. Now we need to learn about what is present anterior and posterior to epiploic foramen. And to learn the anterior and posterior boundary of epiploic foramen, let me take a section at this level. So we are going to take a transverse section at this level, not above. Okay, if I take a transverse section at this level, what is going to happen? The lesser omentum is actually attached here between the stomach and liver. But if I take a section at this level, it is not attached. Now look at this section here. So when you take a transverse section here, on one side there is a liver here, on the other side there is a stomach here, and this is lesser omentum, but that lesser omentum has got the free margin over here, and it is not attached to the liver. Now, as I told you, where is the epiploic foramen? Behind the free margin. Free margin के पीछे. तो यहाँ है epiploic foramen. Here is the epiploic foramen here. Okay. So what do you have in front of the epiploic foramen? You can very, very clearly see from our diagram right now. Anterior to this one here, there is a free margin of lesser omentum. And this free margin of lesser omentum will consist of portal triad. And what is that portal triad? You're able to see there. It's portal vein, the proper hepatic artery, and the bile duct. So what do you find right in front of the epiploic foramen? In front of the epiploic foramen, there will be the free margin of lesser omentum, and there you're able to see the portal triad. What do you have behind the epiploic foramen? There will be inferior vena cava. So anterior boundary, posterior boundary, and then with the previous diagram, we are done with the superior inferior boundary. Epiploic foramen boundaries made easy. No need to mug up at all. And of course, I hope you have learned in surgery, the maneuver which is actually done over here will be the Pringles maneuver. It will be the Pringles maneuver. Now, once you are done with this one, welcome to another very important concept here. What are the derivatives of ventral and dorsal mesentery? Now, my dear friends, try to understand here in this diagram. First, you're able to see here, this one will be your esophagus here, then the stomach here and duodenum. Basically, that is your foregut. There'll be a double layer of peritoneum in the front here, that is mesentery here. And there is a double layer of peritoneum behind here, that is also mesentery here. Ventral mesentery and dorsal mesentery. And you know very well, mesentery is nothing but double layer of peritoneum. And if it is attaching to the stomach over there, of course, what is the name? It is mesogastrium. It will be mesogastrium. So now we need to learn what are the derivatives of ventral mesogastrium and what are the derivatives of dorsal mesogastrium. Now, what is developing in the ventral mesentery? This is liver. Please listen to my English very carefully. I'm not telling liver is developing from ventral mesentery. It is developing in ventral mesentery. It is just developing in ventral mesentery. Now, because of the liver present over here, in front of the liver, there will be a ligament here. This one will be falciform ligament. Between the liver and the stomach, we have seen just now, this one will be the lesser omentum. And covering the liver, there will be triangular ligament, coronary ligament. All this will be actually derived from the ventral mesentery. And then what is derived from the dorsal mesentery? Between the stomach and the diaphragm here, this one will be gastrophrenic ligament. Stomach and spleen, this one here will be the gastrosplenic ligament here. And then between the spleen and the kidney behind, splenorenal ligament or lenorenal ligament. And finally, attached to the greater curvature of the stomach will be the greater omentum. And those will be actually derived from the dorsal mesogastrium. Okay, now, so in this manner, what is going to happen, my dear friends? Yes, by this we can actually remember what are all the derivatives of ventral mesentery and dorsal mesentery from one diagram itself. No need to mug up at all. अगर आपको चाहिए तो हम एक बार और दोबारा इसको रिपीट कर सकते हैं. Let's repeat this together now itself. Nothing to hurry because we are doing the quality work right now. Okay, I hope you are revising everything just before the exam. Liver is developing in the ventral mesentery, number one. Then what is going to happen between the liver and the anterior abdominal wall? This ligament is falciform ligament. Between the liver and the stomach, lesser omentum. Okay, this will be derived from the ventral mesentery. Then between the stomach and the diaphragm, gastrophrenic ligament. And then this one is between the stomach and spleen, gastrosplenic ligament. Between the spleen and the kidney behind, splenorenal or lenorenal ligament. And then finally attached to the greater curvature of the stomach will be the greater omentum. All that will be derived from dorsal mesogastrium. Made easy. Now welcome to rotation of gut. Another very much important topic for your NEET PG exam, hot favorite topic I should say. सबसे पहले आपको पता होना चाहिए foregut is going to rotate 90 degrees, of course in clockwise direction. Midgut is going to rotate 270 degrees in anti-clockwise direction, and hindgut will not rotate. Now about the midgut rotation, many times they have asked the question in your NEET PG exam, and recently this image-based question was given. Okay. Let us discuss everything here. Now, first of all, what is going to happen here is during the rotation of midgut, the midgut cannot be accommodated inside the abdomen. Why? Because this rotation is taking place during 6th week of development. Just imagine 6th week, 1.5 month of the pregnancy. Therefore, the midgut is actually going to come out of the umbilical opening. Now, after coming out of the umbilical opening, the midgut is going to rotate 270 degrees in anti-clockwise direction. First MCQ here, around which artery? It's going to rotate 270 degrees in anti-clockwise around which artery? Remember, that is the superior mesenteric artery. Superior mesenteric artery. Fine. Second thing, if it is coming out of the abdomen there via the umbilical opening, can I call this one as hernia? Of course, it's hernia. Now, is it physiological hernia or pathological hernia? Yes, of course, remember, it's actually the physiological hernia. It's the physiological hernia. Now, the first question that was asked in your exam, when will this physiological hernia occur? Answer, 6th week. The physiological hernia will occur during the 6th week. Now, for this entire rotation to occur and this again going back to the abdomen, reducing back to the abdomen, it is going to take like 4 weeks of time. So therefore, दूसरा सवाल जो पूछा गया था, when will be the reduction of physiological hernia? By 10th week. ये भी आपके एग्जाम में पूछा गया था. So these two MCQs are done here. So it's going to occur. When will the physiological hernia occur? 6th week. And when will it is going to reduce back? That is by 10th week. Okay. Now you and me, thank God, your midgut, my midgut came out, rotated and went back. Okay. Now in some unfortunate babies, the midgut is going to come out, but it will not reduce back. The failure of reduction of the physiological hernia. And that is referred to as omphalocele. Yes, in this omphalocele, sac hota hai ki nahi hota hai? Of course, there'll be a sac because it is physiological hernia. It's not like rupturing and coming out. And intestinal obstruction normally nahi hota hai. Now, what is gastroschisis? Normally, I have seen in the classes, the students are getting confused between these two conditions. In gastroschisis, what is going to happen? Yes, there will be actually herniation of the coils of the intestine from the weak part of the anterior abdominal wall. The anterior abdominal wall will rupture, and yes, there will be herniation occurring there. Therefore, what is going to happen, because it is rupturing and coming out, it is not covered by the sac. The sac will be absent there. And yes, of course, the intestinal obstruction will be most common in this condition. Okay, I hope you all remember right from the first year MBBS days, we remember like this. Omphalocele starts with O, and yes, of course, the coils of intestines are lying inside the sac. Gastroschisis will start with G, and yes, of course, what is happening? The coils of intestines are coming out by rupturing the anterior abdominal wall, something like that. So G is actually ruptured there in the front. So in this manner, there'll be no confusion at all. Now, in NEET PG exam, what was the question asked, guys? The question was about the covering of this omphalocele. What is this outer covering of the omphalocele? Please remember, this outer covering here will be the amnion. So till here, यहाँ तक तो आप सब लोगों ने पढ़ रखा होगा. Now please update there. The outer covering of the omphalocele there will be the amnion. Perfectly done. Now, you all were learning nicely about the muscles of the tongue and nerve supply of the tongue. And I hope you all remember 5, 7, 9, 9, 10, 10, anterior 2/3, posterior 1/3, everything you have learned perfectly. Now from last like 2-3 years, they started giving the questions regarding the papillae of the tongue. There are like 4 different types of papillae. Number 1, filiform, there'll be like thread-like papillae. And then fungiform, the name itself is telling you mushroom-like papillae. Circumvallate papillae are important. This image-based question was given. Now in circumvallate papillae, what is going to happen? They are actually circular papillae from above. अगर आप ऊपर से देखोगे, if you see from above, there will be circular papillae. So upper part will be like more wider, whereas the lower part is narrower. And you will be able to identify this papillae with the help of this trench or groove on either side. So there is a trench or there is a groove on either side of this one. The first thing is done, and don't worry about the foliate papillae, sir. Yes. Now, after that, my dear friends, you have to remember, like, 2 more points here. Out of all the papillae, which papillae does not have the taste buds? No taste buds in filiform papillae. Important point to remember. And normally, we actually assume that in the oral cavity, we'll be having stratified squamous epithelium. And then remember that stratified squamous epithelium inside the oral cavity has to be non-keratinized. Our normal concept says that it has to be like non-keratinized. But out of the 4 papillae, please remember the filiform papillae is the one which will be having keratinized stratified squamous epithelium. Normally in the oral cavity, it has to be non-keratinized stratified squamous epithelium, but filiform papillae has got keratinized stratified squamous epithelium. So please remember these 2 points over here. And of course, circumvallate papillae image-based question was given. Please remember that one, guys. Transitional epithelium, hot favorite of the NEET PG examiner. They have given this many times in your exams. So this image is also important. So in our image-based session right now, I think you're observing there, I'm showing you all the very high yield images that you have to know before going to the exam. Okay, so now please look at this diagram here. How to identify here? Of course, transitional epithelium is also stratified. Multiple layers are there, but you don't have to worry about the basal layers and the intermediate layer. Look at the apical one, the topmost one. In the apical layer, you're able to see like big cells over here, which are referred to as umbrella cells. Why? Because they are the one which are going to cover like almost 2 or 3 cells beneath them. So beneath them, they are actually going to cover like 2 or 3 cells. By that, you'll be actually able to identify them. So you have to be like very much clear about the apical layer, which will have umbrella shaped cells or inverted U shaped cells. And they are the one by which you'll be able to identify. Now this transitional epithelium will be present in number 1, ureter, number 2, urinary bladder, and up to the prostatic urethra. And because it is mainly found in the urinary tract over there, therefore the transitional epithelium, it is also referred to as urothelium. The transitional epithelium, it is also referred to as urothelium. So now, my dear friends, by this, we are coming to the end of our session over here. These are all the images, the high yield images that you have to actually revise in anatomy for your NEET PG exam. Please go through all of them. We have revised all the high yield concepts, including your neuroanatomy, head and neck, embryology, histology. All the high yield images has been completed over here. So try to revise them. It's actually like, once the session is done, I'll even actually share this PDF on my Telegram group also. So you can just keep the PDF in the front, revise this entire video on 2x for like 2 or 3 times before going to the exam. Hope this will help you. God bless you all. Come out of the exam with the flying colors. All the best, my dear friends. My best wishes are with you. God bless you all and be successful in your life. Thank you.